potential predictive or prognostic utility for this test in identifying those people who are most likely to die. Interestingly enough, it's the only TB diagnostic to date that's been associated with reduced mortality. And in this recent multi-site RCT, bedside LAM-directed TB therapy was associated with reduced mortality, but again, this was in adult people living with HIV. So what about children? So in terms of urine LAM, the data is really quite limited in HIV-positive children, and this is a population who is really at high risk at TB-related morbidity and mortality. And really, these children have protein manifestations of TB. They're presenting either with disseminated extrapulmonary TB that's often missed by respiratory sampling. So our question was, does urine LAM predict mortality in HIV-infected children? To probe this question, this study was nested within a larger RCT of HIV-positive, ART-naive hospitalized children at two different locations in Kenya. All children underwent TB evaluation, including 2 either sputum or gastric aspirates for culture, as well as a sample for expert. And again, our primary outcome for this study was 6-month mortality by urine LAM result. Of 181 children who were enrolled in the parent RCT, 137 had evaluable LAM results. 15 children were LAM positive and 12 were LAM negative. This was a young, highly immunosuppressed population. Median age was 26 months, and 70% of these children would be considered HIV to have severe immunosuppression per WHO guidelines. 7% of children had confirmed TB, that is, they were either culture or expert confirmed TB, and 43% had unconfirmed TB. And this is using the Graham guidelines. Overall mortality in this cohort was incredibly high. 15% of children died, giving us a mortality rate of 40 per 100 person years. So did urine LAM predict mortality? In this cohort, it did. So what this graph shows, the orange bar is LAM positive children, and amongst LAM positive children, overall mortality, 40% of those children died. Amongst LAM negative children, 12% died. Now when we're looking at the risk of mortality over 6 months, you can see that the risk of mortality amongst LAM positive children was greater than 3.5 times higher compared to LAM negative children. And what if when we're looking at who had TB or not? So our primary endpoint was all-cause mortality. When we further stratify by children who had confirmed and unconfirmed TB, as well as unlikely TB, you can see in this group of kids with confirmed and unconfirmed TB that their risk of mortality was actually 9 times greater if they were LAM positive compared to if they were LAM negative. So LAM predicts who will die, both overall as well as amongst those children who either have confirmed or unconfirmed TB. So in conclusion, again, we found that in our study, urine LAM really predicted overall mortality in this population of hospitalized HIV-positive children in a high TB burden setting of Kenya. And importantly, this included children with unconfirmed TB. And that analysis, I showed that overall mortality, I had both confirmed and unconfirmed TB, but that risk is actually really driven by the population of children with unconfirmed TB. So this test is identifying children who are likely missed by respiratory sampling, who are at highest risk of death. So this test identifies children who will die. However, the big question is, can we use this test to see, can we prevent mortality by using that test? And really, that's the next question. Thank you.
Awesome. Thank you very, very much. Excellent presentation and wonderful timekeeping. We have time for a couple of questions. Can I open up any questions, thoughts, comments? Yeah, at the back, Lisa. You might have, there's a microphone right at the front if you want to run very, very quickly to the front. Andrew's going to come in with a question while we're waiting.
Thank you, Sylvia. That was terrific. Quick question.
Yes.
The role of malnutrition in your cohort?
Yeah, so that's, I don't have it on that table, but the median weight for age Z-score was, I think, 2.3 or 2.5. So this was a very, you're right, I don't have it on that slide, but I would consider this a very malnourished cohort. What I have, and it would be interesting, we should actually stratify by malnutrition, which we haven't done yet. Excellent question, thanks.
Question, Lisa?
Great, Lisa Adams from Dartmouth. Thank you for that great presentation, Celia. I wanted to ask, though, about your last point, actually, because that's sort of like, that's a conversation starter, right?
Right.
Do you have thoughts about how you might incorporate this into testing? Like, what would that protocol look like? How might we make this useful?
So that's an excellent question. I mean, I think there's really two questions. That Peter RCT was fantastic, and really what that was bedside LAM-directed therapy. So a nurse did the bedside LAM, and if it was positive, she made a recommendation to the attending physician, potentially we should start treatment. And then that decision was made. So probably that benefit was early treatment. So I think in that population, in hospitalized sick kids, it would be your bedside test that you do pretty quickly after admission. What we don't know is, I'm interested in, can you use this earlier on, right? The rates of mortality in this cohort were so incredibly high, right? So can we use it as more of a predictive test earlier on? So when they're coming to clinic, et cetera. So really, I think these are two really interesting questions.
Okay, I'm afraid we are so tight for time. We're going to have to move on. Sorry. We're going to thank you very much, and we're going to invite the next speaker, who is Helena Höger. Have I said that correctly? Who is going to give her presentation.
Sorry, I'm not sure what I should do. Good afternoon. So, I'm going to present on the incidence of latent tuberculosis infection and tuberculosis disease in pediatric contacts of patients with drug-resistant tuberculosis in Armenia. So we know that child contacts of adults with tuberculosis are more likely to become infected and also have a higher risk of progressing to active TB disease. And the current guidelines recommend preventive therapy for asymptomatic pediatric contacts of susceptible TB when children are less than 5 years old or are HIV positive. However, recommendations for the management of children that are exposed to drug-resistant tuberculosis are controversial. So in this study, we measure prevalence and incidence of TB infections and TB disease after 24 months of follow-up in children that were contact of patients with drug-resistant tuberculosis in Armenia. This was a prospective cohort study. We included children under 15 years who had regular contact with newly diagnosed drug-resistant tuberculosis patients. We included patients from 2012 to 2014, and we followed them up for 24 months. And these children did not receive chemoprophylaxis. So these are the study procedures. After identification of the contacts, the children had an initial assessment that was done through clinical examination, TST, IGRA test, and chest X-ray. If they were suspected of TB, a smear and culture were also performed. Children that were diagnosed with tuberculosis were treated, and those that were infected or non-infected were followed up for 24 months every 3 to 6 months with the same exams that I have mentioned. 150 children were included in the study, and 125 completed 24 months of follow-up. Median age was 6 years. Very few were malnourished. Majority had the BCG vaccination, and none of them were diagnosed with HIV. Half of the children of the pediatric contact were children of an index case, and a majority had a daily contact with the index case. So here are the main results of the study. Overall prevalence of latent TB infection at baseline was 55%, slightly higher in the cohort of children 5 to 14 years. Incidence was 17.4 per 100 person years. 2 children were diagnosed with TB disease at the initial assessment. Both of them were age less than 1 year. and so that translates in a prevalence at baseline of 1.4%, and among children 0 to 4 years old, 3.6%. There was no TB disease diagnosed during follow-up, so the incidence of TB disease was 0. We look at factors associated with LTBI. At baseline, having been 5 to 14 years old, being exposed to more than one case with DRTB, additional to the index case, and being in contact with an index case that was smear positive were associated with LTBI at baseline, and being in contact with an index case smear positive was also associated with being infected at 24 months. So in conclusion, we found a high prevalence of LTBI at inclusion. There was no TB case of TB disease diagnosed during follow-up. However, we found 2 cases that were diagnosed at baselines. So we think that these findings do not support the indication of systematic DRTB prophylaxis in this setting. However, a screening of symptoms for symptoms of TB disease in children that are contacts of DRTB patients is highly recommended, and particularly in those that are infants and contacts of smear-positive cases. Thank you very much.
Another very interesting presentation, and also very well kept time. Do we have any more questions on that presentation? Any thoughts? Well, in the absence of that, I'm just going to quickly ask a question. Very, very interesting that you saw no cases of incident TB disease in those who had a positive test of infection within 2 years, young children. In other studies, people have shown much higher rates in Peru, in South Africa. How do you understand those differences between your findings and other findings?
So we think that probably the context and the clinical status of the children has a lot to do with the development of the progression from latent TB infection to TB disease. These children, there was none that was HIV positive, very few well malnourished, and we are in Armenia. It's a context completely different than South Africa, where completely different findings have been found, and much more TB disease in contact of pediatric contact of DRTB cases. So probably the situation and the progression to TB disease is very different according to the patient itself and also the context where the patient lives. So that's our interpretation.
Very interesting. Well, in the absence of any further questions, thank you very much. We'll move on to the next talker, Jennifer Guthrie, who's going to give us the next talk.
Okay, good afternoon. My name is Jennifer Guthrie, and I'm going to talk about tuberculosis transmission related to pediatric patients in British Columbia, Canada. So I'll often refer to it as BC for short. So the picture of BC here, so it's the westernmost province in Canada, and as you can see, we're low incidence, although we are slightly above the incidence across Canada. We have a very low rate of pediatric TB, so of our culture-positive diagnoses, about 2%. So that gives us 49 cases over a 10-year period. The limitation of what I'm about to talk to you about is obviously that pediatric TB is often not culture-positive, but is required to be culture-positive to enable us to do molecular studies. Just to give you an overall idea, in BC, about 80% of our TB diagnoses are in foreign-born individuals, but our pediatric cases are only about 50% foreign-born. And because pediatric TB often signals a sentinel event of transmission, and transmission is obviously occurring within Canadian-born patients. The median age is a bit different depending on if you're looking at Canadian-born versus foreign-born patients, and we defined pediatric as any child less than 18. So most of you are probably familiar with Miravinter, so it's one of the strain typing techniques and is pretty much the most universally used strain typing technique at this point. And if you see in the top right corner there, about 50% of our pediatric patients have a unique Miru-Vinter pattern, meaning they don't match any other patient, either adult or pediatric patient, in the province. Meaning that they've likely acquired TB either through travel and or prior to their entry into Canada. So if we look at the ones who do have a genotype match within the country, within BC, there's some very different Miru groups that they belong to. So each one of those bars is a single Miru group. So we have some very large endemic transmission on the left there of Canadian-born patients. And in a couple of them, there's multiple pediatric patients within the Miru cluster. So 2 with the 2 asterisks, and there's 3 in one of the other clusters, what we consider a more foreign-born cluster. So Miru-Vinter can be really helpful, but unfortunately it will tell us who clusters together, but not necessarily who transmitted to who. And in some cases, and in these particular cases, it can be fairly easy to figure out, and the whole genome sequencing can be more of a confirmation of what you believe. And because I have such a short period of time, I've chosen to show 2 examples that are quite straightforward, but we have other more complex examples where genome sequencing has really revealed transmission that was undetected or unknown. So on the one case there on the left, so this is cluster 24, we actually have, this is actually 3 generations, but we suspect there's a 4th person involved here, the great-grandfather. Unfortunately, his culture-positive isolate was prior to our strain collection back in the early 90s. But great-grandfather, grandfather, mother, child, all culture-positive, confirmed tuberculosis. The grandfather, mother to child, and so the transmission definitely occurred in that way, and you can see that there's just a single SNP between grandfather and then mother and child. But the grandfather passed away prior to the child's birth, so when we combine epi data with the genome sequencing, we can definitely confirm that went from grandfather to mother to child. The other case on the right-hand side, cluster 187, is what we would consider a foreign-born cluster. The only Canadian-born individual is our pediatric case. Both parents were foreign-born, and they're a Miru cluster, and it wasn't quite clear potentially who the transmission was because both parents had the same Miru pattern. But when we do whole genome sequencing, you'll see there's an asterisk up at the top there, which is one parent, and then in the blue is the other parent. So even though they have the same Miru-Vinter pattern, and they're obviously from the same area of the world, that clearly one parent was the transmitter of TB to the child, and the other parent just coincidentally also had TB, and neither gave it to one another. So genotyping results can quickly refute transmission, but it can definitely overestimate true local transmission. And for us, our pediatric transmission is estimated at about 30%, which is quite a bit higher than our adult estimated transmission in BC. So genome sequencing, when we pair it with epidemiology, can really provide some refined predictions of transmission. And so this represents an important tool that can really help contact investigations, especially which are very heightened in pediatric tuberculosis, and hopefully make a better use of what we all know to be limited public health resources. And if we can really, especially when we can refute transmission, very helpful, and also to confirm and dig up sort of those unsuspected transmissions. So with that, thank you.
Any questions on the study there?
Yeah, that's hard to say.
Could you repeat the question?
Yeah, sorry. Was mother in the grandfather to mother to child transmission chain? Hard to say, but she was definitely infected based on the timeline, at least prior to pregnancy, and whether she either reactivated that part's unclear. Unfortunately, the genome sequencing, that's when you really need to dig down into the epi. You need both. Some people really like to rely on the genome sequencing, but you have to have all the epi data. We're still collecting the rest of the information for those cases, but sort of 4 generations of TB, unfortunately. There's some comorbidities there too, so.
Excellent. Any further questions? Got time for another one? Okay, well, I think you've answered all their questions. Thank you very much. And can I introduce our next speaker, Aparna Mukherjee? Is she here? Yes, sorry. Great.
Good afternoon, everybody. I'll be discussing the influence of ABCB1 polymorphism on the plasma concentration of rifampicin. As we all know, there is a lot of inter-individual variability in the concentration of rifampicin, and amongst the various factors that might be influencing this variability, the genetic makeup of a person might also be one of the important contributing factor. And as we know that ABCB1 gene encodes for PGP, which is a very important efflux protein found in the border apical side of the intestinal mucous membrane, and the change in its expression might lead to the change in the concentration of the PGP protein, and that could lead to increase or decrease in absorption of rifampicin. With this hypothesis, the objective of our study was to see if there was any association between this particular ABCB1 polymorphism, the mRNA expression of the ABCB1 gene, and the plasma concentration of rifampicin in children. So the study was conducted in All India Institute of Medical Sciences, New Delhi, India, in a cohort of children 6 months to 15 years of age who were diagnosed with probable intrathoracic tuberculosis and were started on category 1 antitubercular therapy. The study was approved by the Institute Ethics Committee. Informed written consent was taken from each parent. And the pharmacokinetic study was conducted after 15 days of antitubercular therapy. And this was a truncated sampling since we were dealing with children, and 5-point sampling of 0, 1, 2, 3, and 4 hours were taken. The rifampicin concentration was measured by LC-MS. The genotype measured or was seen by the PCR-RFLP method, and we also did a relative quantification of the mRNA transcript of ABCB1 gene by real-time PCR. And the pharmacokinetic parameters that we are going to talk about are the 2-hour concentration, the maximum concentration, and the AUC of the rifampicin. So this was our cohort, which included 88 children, the mean age being 110 months, 50% of them being girls, and the weight for age, height for age, Z-score were all on the lower side. Microbiological confirmation either by ZN staining or by liquid culture were obtained in 50% of the patients, and 24 children out of this had HIV co-infection. So what we found was the heterozygous CT genotype was found in around 64% of the children. The wild type CC was found in 2.9%, and the TT variant was found in 32%. And interestingly, the maximum concentration of rifampicin did show some variation with the genotype, the lowest one being in CC, followed by the TT genotype and then the heterozygote genotype. But when we looked into the mRNA transcript in 57 patients, we could not find any association of the mRNA, the quantitation with the concentration of rifampicin, neither with the genotype. So we conclude that with the higher Cmax was found in the heterozygote group, and the lowest was found in the wild type, which we assume has the highest concentration of PGP expression. So that would lead to more of efflux of the rifampicin, less absorption, and the lowest concentration. But the expression actually could not be correlated with the plasma concentration. But PGP being an important efflux protein, and if we do have a relationship with the plasma concentration, blockers of PGP, as in some studies earlier have shown, can lead to an increase in the serum concentration of rifampicin and might be a factor in the problem of low concentration that we face with rifampicin in children. Thank you.
Thank you very much. Very interesting. Any thoughts or comments or questions from the floor? Nothing from anyone? I would just ask, and I mean, you may not know the answer to this, the distribution of those genotypes that you saw in the children, do you know anything about the global distribution in other countries, other contexts, about children or people with other ethnicities, how these different genotypes are distributed?
Other studies have looked into this distribution of this genotype in Indian population in correlation with other drugs, because ABCE1 being an important efflux protein. There the distribution is similar, that being the CC being the wild type being the lowest one. But in some other populations, particularly in the extreme or in that is the Japanese population, there we've seen a reversal of this with the CC wild type showing a higher genotype. So there is a lot of ethnic variation with this particular genotype.
Okay, anything else? Okay, thank you very much. Very interesting. Okay, so moving on to John Paul Dongo, who's going to come and talk to us next.
Hello, how are you? My name is John Paul Dongo. I come from Uganda. And today I am going to present a topic called Engaging the Community to do TB Household Contact Screening, Improved IPT Uptake Among Child TB Contacts Under 5 Years. This is just part of a project that was implemented in Uganda called Detect Child TB Project. And this project had about 3 components. 1, child TB case finding. 2, treatment outcome. And 3, putting children on preventive therapy. So my section really is to share the component of initiating children on IPT. So a brief background about this project. Children under 5 years, those are 0 to 4 years, living in contact with persons with a smear-positive TB, are at high risk of TB infection and TB disease. But also in addition to that, active screening of child TB contacts and provision of isoniazid preventive therapy is very effective in preventing TB in children. So WHO recommends that children under 5 years, irrespective of HIV status, and those above 5 years who are confirmed to have HIV, living in contact with smear-positive TB patients, but in whom active TB has been excluded, are eligible to IPT. More to that, Uganda, in the year 2015-2016, only initiated 5.7% of children under 5 years who are eligible to IPT on preventive therapy. And in my country, we have community workers. These are referred to as VHTs, and they are part of the Ministry of Health structure, but they are not really utilized to identify IPT eligible children from the community, to, of course, through things like contact tracing, and therefore this has been a very big contributing factor to preventing accessing children who are eligible to IPT to the health facilities. So in the year 2015-2016, the union, in partnership with the Ministry of Health, National TB and Leprosy Program, Baylor College Uganda, and Mildmay, did implement a project in 2 districts, that's Wakiso and Kabale district, to do TB case finding, improve treatment success in these children, but also improve IPT uptake for these children that were identified in the community. So what were the interventions? In the community component, VHTs were engaged to do household contact screening, identify and refer children from the community to the health facilities who are eligible to IPT. Engaging is a big word. It has a lot of things to do with training, providing recording tools, providing support supervision, mentorship for the victim to ensure that they're able to carry out the right thing in the community. So what was done, at the end of 15 months of implementation, an external evaluation was carried out. These are the results. A total of 1,326 households of smear positive TB patients were contact traced. In these homes, a total of 1,839 children were screened for TB symptoms and IPT eligibility, and of these, 996 were children under 5 years. That's 0 to 4 years. So of the 996, 78% were eligible to IPT, but of those, only 72% of these were put on IPT compared to a national average of 5.7% with a completion rate of 87%. Contacts above 5 years did not receive IPT because we did not implement HIV testing. So what's my conclusion? Engaging the community, VHTs to do household contact screening is a very effective strategy to improve IPT uptake among children under 5 years. But also, if we're able to provide HIV testing to children above 5 years, this will also be able to improve further IPT uptake among that particular group of children. Yeah, thank you. I'd like to say thank you to our founders, Elmer Foundation, and the Union North American Office. I'll also want to say thank you to Ministry of Health, National TB Literacy Program, Uganda, for the continued guidance on our policies and monitoring of the project, to our 2 implementing partners, Baylor and MildMe, and to 2 of our implementing districts, Kabarole and Wakiso District. Thank you so much.
Wow, very impressive. Well done. Any questions from... Yes, are you able to take the microphone or shout very loudly?
Please, I didn't get you so well.
So I think you said, can you say anything about the side effects of treatment? Okay, sorry, I didn't hear that. Do you want to take the microphone and have a quick... There is another one.
I would say that the side effects and also the willingness of parents allowing their children taking the treatment without symptoms.
Yeah, of course, IPT has some side effects, but I would like to say that in the project that we did implement, not so many of the children were able to show side effects, but I am sure that it's a drug that if taken by children really, the side effects are there. But as a project, children that were put on IPT were monitored on a monthly basis. So if any child really developed any side effects during the time of taking medicines, definitely the health workers would be able to address the side effects for IPT in the children. Second question?
About parents' attitudes.
Yeah, of course, we had some challenges. That's why you saw we had about 72% of children getting initiated on IPT. We had that 28%. Some of them, of course, failed to access IPT because of the distances to the health facility. Some parents didn't really think it was good for them to put their children on IPT, them thinking their children were normal and not suffering from anything. So they also felt there was no need to put their children on IPT. Thank you.
Maybe one other quick question. Congratulations on your work. I'm here to your left. Superb stuff. Did you notice a difference in the IPT uptake by different village health workers? In other words, were some village health workers better at convincing people in their village compared to others? And if you haven't looked at that, that's fine.
I would not say we had a difference, but what I would like to say, these are things I didn't really share with the team. The VHTs were also received a monthly facilitation, which was performance-based. So based on this, every village person really was eager and willing to make sure that the people they were supporting are able to take their medicines as required. Yeah, thank you. Thank you.
Thank you very much.
Okay, thank you.
So we'll invite up our next speaker, Heidi van der Venter. Thank you, Heidi.
Good afternoon. Can you hear me? Afternoon. Thank you all for coming. So my name is Heidi van der Venter and I come from the Destiny 22 TB Center. The title of the study that we were working on is Tuberculosis infection is inversely associated with atopic symptoms in HIV positive and negative South African children. So to give you a bit of a background, the World Allergy Organization, they define ATP as having allergic symptoms, and then you have to have an objective measure as IgE and skin prick testing. Unfortunately, with the study that we did, we only have the ATP symptoms and we don't have any objective measures. So, as we know, there's a big rise in ATP, and this has been partly explained by the hygiene hypothesis. The hygiene hypothesis is based on the T helper 1 and T helper 2 immune balance. So I know it's actually very much more complicated than that, but that is like the basic where it comes from. So why would we be interested in seeing an inverse relationship between TB infection and allergic symptoms? It's that it could be very interesting and lead us to a mycobacterial-based vaccine against ATP. So the objective of our study was to investigate the association between mycobacterium infection and the symptoms of ATP in HIV-infected and uninfected children in a setting with a high burden of TB and HIV. This was a sub-analysis done, a secondary analysis in a large prospective cohort study. It was based in Cape Town, South Africa. So we identified the adults with TB at the local TB clinics, and then we went to the households and identified the children as household contacts. And then we went to the neighboring households, and we also had the neighboring children as a baseline of the infection status. So we assessed them at enrollment, month 3 and month 6, and then the TB infection status was done at baseline and then at month 3 again. And the atopic symptoms that we investigated were based on the ISAC, the well-known ISAC questionnaire. So what we found was that the majority of children were under 6 years of age, with a median age of 5. And then the mixed race ethnicity was the largest. 15.5% of the children were HIV infected. And then the TST positive, the HIV uninfected children, 42.3% were TST positive. And then the HIV infected children, 28.9% were TST positive. So when we did our analysis, we saw that children with a negative TST were more likely to have atopic symptoms, as well as HIV-infected children were more likely to have atopic symptoms, children younger than 6 years, and then closer children. I'm going to show you the tables of the main analysis just now, and just to tell you that we also did a sub-analysis in children younger than 2 years of age, where we did not find this inverse association. And then when we did a sub-analysis between HIV positive and HIV negative children, we actually found this inverse association only in the HIV positive kids. This is the table of the main analysis that we did. So during the univariate analysis, we did find an inverse association between positive TST at baseline and wheezing at month 3. And then we also found this inverse association between positive TST and eczema, and then also a association between hay fever and month 3 TST. Unfortunately, when we added all the factors that we thought were necessary and clinically significant into the analysis, this inverse association disappeared. So we thought that age Tulsa ethnicity and HIV infection were important to include in every model as they were clinically significant. What we did find was between the positive TSC at baseline and wheezing at month 6 is that the inverse association actually continued when we did the multivariate logistic regression, adjusting for age, Xhosa ethnicity, and HIV infection. So I would just like to spend a moment to discuss what we thought the implication of our findings could be, and it's great. So there were a lot of studies done that has found this inverse association, and we confirmed then this cross-sectional inverse association, but what we also then add to the literature is that the longitudinal inverse association. And we were thinking that these results were quite interesting, as it might lead to a vaccine, mycobacterial vaccine against atopy in the future. And I would like to acknowledge the co-authors and the sponsors. Thank you very much.
Thank you very much, Heidi. The presentation is open for questions, discussion. Maybe while you think about your questions, I'll just ask one. Thanks for an interesting presentation. Just thinking about the symptoms of allergy, I don't know the Isaac symptoms well, but did you guys look at other potential confounders, for example, the use of wood smoke in the home?
Yes, we actually did look at a few confounders. So we, all the confounders that had an association with the atopic symptoms that had a p-value of less than 0.15, we actually did include them in the model, but if they had the p-value of less than 0.15. Yeah. So we looked at tobacco smoking in the household and prior TB treatment and a lot of different confounders.
Okay, you're hearing a lot from Andrew and I. We won't need more questions from the floor. But in the absence of that, I was just going to ask, you didn't see an effect in the under 2-year-olds. Do you think there's a chance that effect might have been masked by BCG vaccination? Is that one of your working hypotheses? Because everyone would have got BCG whether they had TST infection or not?
It might be the BCG vaccination, but I think there's also a lot of other illnesses in under 2 years old that can mask the symptoms of allergies, like bronchiolitis that causes wheezing and asthma, or not asthma. So I think that is why it actually strengthens our findings.
Thank you very much. I'll invite our next speaker, Xiaolin Wei, up to the podium. Thank you, Xiaolin.
Oops. Don't know how to go, but go to the beginning. Okay. Good afternoon, everybody. My talk is in the middle, but I'm not talking about TB, talking more about antibiotic resistance. And we are, we're in the TB world, but we also, TB patients come from cough, and they go to the general practitioners or go to the respiratory clinic. And then we see that in many countries, there's a big kind of overuse of antibiotics for these patients. So I'm going to talk about a trial to reduce antibiotic use among the pediatric patients. So because we think that there's specifically a danger and also overuse antibiotics for children. I just get a quote from Sir Fleming when the penicillin was discovered. He said one day there would be somebody who will kind of overdose of the penicillin, and then it will be resistant. So unfortunately, it comes very quickly after that. And also, we want to be reminded about the WHO publication of the most dangerous pathogens, and then later with the effort of the union and all other organizations, we've listed MDR as one part of the most dangerous pathogens, but we just get reminded that TB is a part of the respiratory physician's work, and we have to look at all the different pathways of patients. So regarding antibiotics used in China, I think that I do not need to say too much. It's really kind of overuse. If you look at the use per patient in China, it's almost that 10 times of that in the United States. So if you look at outpatient use for the common colds, we call it upper respiratory tract infections. In China, it's about 70 to 80%. While in the other parts of the world, it's almost the same in the developing countries, but it's about 30 to 40% in the developed countries. And we also look at the policy. There has been the policy put out by the Ministry of Health and Family Planning in China to reduce antibiotic use. But from the studies, we haven't found that the policy have been effective in bringing them down. And then we look at the trials that has been done worldwide. It has been tried that most trials were done in developed countries, have reduced antibiotic use for about 5 to 7%. And there were some smaller trials, but there haven't been a trial done in the developing country looking at this issue. And also we know that the trials, they have at least two factors. One is the providers, like guidelines, training, prescription review, etc. Another part is the patients, health education, health promotion. We find that trials have to look at interventions for the two sectors will achieve the biggest effect. Here is a setting we did the trial. It was in the southern border of China, bordering with Vietnam and Laos, and in a minority places called Guangxi. And we chose two counties, and we break them into the townships, which are the primary care facilities. So we have a total number of 12 in one county and then 15 in another county. And then we did not choose the county center, township hospitals to avoid confounding, but we randomized the rest into the intervention or control. And also we get to know that if you look at the antibiotic use rates among the children who have upper respiratory tract infection, you'll find a high risk usage among the children in the township hospitals, which are the major primary care providers in the rural areas. And for the intervention, we have done two parts. On the doctor side, we designed clinical guidelines, and then we did the training for how to treat a patient with common colds, with upper UITI. And then we look at which condition antibiotics should be used and which condition it should not. And also we give a brief message from the doctor to the patient, say that why antibiotics should not be used and what is the danger to the child. As well, we have the control, and in the control we use Eurocare, so there's no guideline, but other policies of government implemented in the Eurocare group. The primary outcome is look at antibiotic usage rate among the patients, pediatric patients who are diagnosed of UITI. We exclude anything who diagnosed with lower tract infections. And we also have the secondary outcomes about two more antibiotic usage and also about the usage, the cost, etc. Those are the pictures about prescription review. And I'm not going to go too detailed into that. So basically, we selected all the patients in the setting. So there were over like 25,000, and then we randomly selected them for the analysis, about 5,000. So in total, we have looked at the usage rate, and they were similar from the beginning, about 80%. And well, after 6 months, we have brought down to almost like 30% of the absolute risk, meaning that we brought down from about 80% to about 40% in the intervention, while in the control, there's a little difference between the two times. And which is interesting about, we put them along the different months. We can see that there was no difference at the baseline, and there was also no difference in the first 3 months, while the change began after month 3 until month 6. We also look at the difference regarding antibiotic uses per cluster. We could see that there are wide differences in the intervention, from about 80% down to about 20% down, while there's almost no difference in the control. We also did a process evaluation to look at it and find out that clinical guideline is a foundation, but peer reviews are the most important factor to change. I think the conclusion is that the trial has been effective in reducing antibiotic usage for children in the primary care settings. And that is a reference and acknowledgement to the funding and our partners. Thank you.
Thank you, Xiaolin. Questions, comments from the floor? Yep.
Hi, in your setting, what proportion of antibiotic use is actually parents going to the chemist and buying it directly, so circumventing the health system? And do you think that the majority of antibiotic use is happening in this in that setting as opposed to directly in the healthcare system? And then how would you involve chemists in this?
That is a really good question, because in many developing countries, antibiotics are freely over the counter. But in that setting, it has been national policies that no antibiotics can be given in the pharmacies. So there was not a big problem, but we are going to do similar work in Cambodia, and then that would be a very major factor.
Thank you very much, Xiaolin. I think we're going to move on, but please do catch Xiaolin later. Our next speaker is Neeraj Raizada. Welcome.
Good afternoon, everybody. I'm presenting results from a pediatric project which we implemented in India. This initiative was funded by USAID under Challenge TB initiative, and FIND was the implementing partner. Just briefly about the project design. Here we basically implemented the WHO guidance on providing upfront expert testing for children, and I'm presenting data over the 9 quarters starting April 2014. The pediatric age group over here is defined as 0 to 14 years age group. I'll just introduce you to the project design. So we implemented this project in 4 largest major cities of India. So namely Delhi, Chennai, Hyderabad, and Calcutta. Idea being that we, being the largest cities, so we would be able to make a maximum impact in these cities. The testing was done through a hub and spoke model where a single high throughput lab covered each of these cities and provided free of cost testing to all pediatric presumptive TB cases. Rapid specimen transportation linkages were established through the centralized lab with all various public and private sector facilities across the city. And we tested all types of pulmonary and extrapulmonary specimen from the children. One very important aspect of the project was the turnaround time. We ensured that all specimens were transported on the same day, tested, and results reported electronically and by short messaging services to the providers on the same day. And all cases were offered linkage to free of cost treatment under our NTP. So these are the key results which we found under the project. If you look at it, we enrolled something like 42,000 pediatric presumptive TB cases across these 9 quarters, across the 4 cities. By sheer size of the cohort, this is easily the largest global initiative dedicated to pediatric population. We got something like 8% TB detection rate under routine settings, and the MDR rifampicin resistance levels which we observed under the project was 8.8%. Overall, 90% of the rifampicin sensitive cases and 87% of the rifampicin resistance cases were initiated on treatment. And the turnaround time under the project was quite good in the sense most of the specimens, the median turnaround time for transporting, testing, and reporting results was within 24 hours. And we were able to achieve a rapid treatment initiation with RIF-sensitive cases initiated on treatment within 3 days, and rifampicin-resistant cases with a median time of 8 days. With this quick turnaround time, what we saw that the treatment success rates were quite good, and very importantly, together treatment failure rates and treatment default rates were exceptionally low. Together, they constituted 0.7%. Now, usually, I would attribute this to upfront expert testing because children got the right regimen upfront, so the treatment failure rates were quite good. And the quick turnaround time, like parents seeing a very responsive system, sort of felt obliged to not default. So, so those rates were quite low. Yeah. We tested something like 46,000 samples from 42,000 kids, and only 40% of the samples were sputum or induced sputum, and we were able to capture large data on different types of specimen. Overall, I'd just like to flag that detection rates were good on all types of specimen apart from pleural fluid and ascitic fluids, where we didn't see any additional yield over and above microscopy. Another important point I would like to flag over here that what we saw that most of the cases, like on a single test, 92% of the cases from the project cohort could be detected. Wherever the clinical suspicion was high, the providers were encouraged to send a second samples. Another 6.1% incremental yield was seen on the second sample, and cumulatively 98% of the cases were detected on the second test. Beyond the second test, we didn't see much more additional yield. I would like to stress on just 3 key findings from the project. Maybe the time is too short for that as well. The TB detection rates were 2-fold higher in females as compared to males. Now, if you look at the sample size, it's quite significant. And we did a lot of analysis around the data, and we couldn't attribute this to variation in age, prior history of TB treatment, or sectoral variation. And the median age of males and females was quite comparable. So probably, and now in the context of this project, we are talking about the largest cities of India, like where you would see more development. So attributing this to malnutrition or some things like that does not make sense. So, but this is an important finding. I thought it relevant to share on this forum, and probably requires more research. Another key aspect which we observed, now MDR in children is rarely suspected, and usually it's the first line drugs which are prescribed. We saw continuously high levels of MDR, and 8.83% of MDR on a very large cohort of pediatric suspects was seen. Most of the cases were treatment naive, and high levels were observed in all cities, and we couldn't see any clustering around any particular facilities or time period or any sector. And if you look at the sub-age groups of the pediatric population, MDR levels were high in all 3 pediatric sub-age groups. For 0 to 4, I would say 6% is quite high, and this comes from a very large sample size. The point I'm trying to drive over here is that we need to take MDR in children quite seriously, and frankly, it's quite an ignored thing nowadays. And the last point I would like to try to make is the replicability. With the NTB, under the NTB strategy, there is a call for providing upfront access to high sensitivity diagnosis. Unfortunately, this high cost of expert infrastructure and everything limits its applicability for upfront testing. what we piloted over here were a single lab catered to the largest cities of India. And frankly, India is a high population country. So these were the four largest population cities of India, and we were able to maintain a very quick turnaround time. So this provides a very feasible option for providing upfront testings in other settings and replicated in other places. Thank you.
Thank you very much, Neeraj. Questions?
Thank you for the presentation. Interesting. I'm interested in knowing the positivity rate disaggregated by age, the 0 to 4, 5 to 14. We saw the reef-resistant bit, but the general one. Was it different in the two age groups?
Sorry?
The positivity rate for the 0 to 4, 5 to...
TB positivity was highest in...
That's for reef resistance. I mean, even the general...
Yeah, TB positivity was highest in the 10 to 14 age group and was slightly lower in 0 to 4, which you would expect because the sample quality would vary in these age groups. But that you would not attribute to, wouldn't be related to the MDR levels.
Of the 41% of the sputum specimen that you got, what was the proportion for children under 5 years? The specimens on sputum, what proportion was for children under 5 years?
Actually, I couldn't get that question.
So, of the sputum samples that were positive, what proportion of them were children under 5 years? If you don't know, it's okay.
I won't be able to.
Okay.
I can get back to you later.
Thank you very much. Thank you. I'd like to invite our next speaker, Rewa Chowdhury, up to the platform. Thank you, Rewa.
I can barely see over this platform. Thank you. So today I'll share my analysis of the use of the monocyte to lymphocyte ratio to diagnose tuberculosis in HIV-infected children. Tuberculosis disease is a leading cause of mortality in HIV-infected children, but TB is difficult to diagnose in children given possibacillary disease and the challenges of obtaining adequate respiratory specimens. Host biomarkers may provide an alternate method for rapid diagnosis, but many may not be available in resource-limited settings. The elevated blood monocyte to lymphocyte ratio, or MLR, may be a promising diagnostic TB biomarker. In the host, TB-infected monocytes proliferate, whereas lymphocytes are the primary effector cells of the immune response. Therefore, an elevated ratio of monocytes to lymphocytes may be an indicator of TB burden in a host. In previous studies, Narenbai and colleagues have demonstrated that in children aged 3 months, those with elevated MLR had a higher risk of TB development by 2 years of age. They also, in a different study, have shown that MLR had high sensitivity and specificity for the diagnosis of TB in adults. However, the TB diagnostic performance of MLR in HIV-infected children has not been evaluated, and few studies have looked at longitudinal changes in MLR as a potential indicator of TB treatment response. We investigated the association between baseline MLR and confirmed TB disease. We also evaluated changes in MLR over the 6-month study period. Our study was nested within a randomized clinical trial of HIV-infected children, hospitalized and starting antiretroviral therapy. At enrollment, all children received intensified TB case finding, regardless of symptoms. They were then classified into 3 groups based on Graham and colleagues' criteria. So children with positive culture expert were in the confirmed TB group. Children in the unconfirmed TB group had 2 or more of the following: TB symptoms, an abnormal chest x-ray, positive tuberculin skin test, history of TB exposure, or response to TB treatment. Children in the unlikely TB group did not meet criteria for unconfirmed or confirmed TB. We measured absolute monocyte and lymphocyte counts using complete blood count and differential at enrollment for 12 and 24 weeks. So 179 children were eligible for our study, 14 were in the confirmed TB group, 77 in the unconfirmed group, and 88 children were unlikely to have TB. The distribution of age and baseline CD4 percentage was similar between all three groups. Baseline weight for age Z-score was different only between unconfirmed and unlikely TB. At enrollment, the median MLR in the confirmed TB group was 0.43, which was higher than the median MLR in the unconfirmed TB group, 0.22, and the p-value for that comparison is less than 0.01. Confirmed TB MLR was also higher than the median MLR in the unlikely TB group, which was 0.22 at p-value of 0.01. Unconfirmed and unlikely groups had similar MLRs at enrollment. We then evaluated the diagnostic performance of MLR. So looking at sensitivity and specificity on the y-axis and MLR cutoff on the x-axis, we found that above an optimal cutoff of 0.38, the sensitivity and specificity of MLR in identifying children with confirmed TB disease was 79% and 75%, respectively. And the corresponding area under the curve there is 73.73. Looking at MLR on the y-axis and time on the x-axis, we see that by 12 weeks of TB treatment, children in the confirmed TB group, the median MLR for them declined to levels similar to the unlikely TB group. In our generalized estimating equations model controlling for time-varying CD4 percentage and visit week, the confirmed TB group MLR was higher in comparison with the unlikely TB group at a significance level of 0.02. In conclusion, we found that higher MLR was associated with confirmed TB disease. The diagnostic performance of MLR in our cohort is fairly similar to other rapid diagnostic tests for microbiological confirmation, such as nasopharyngeal aspirate or stool expert testing. However, MLR is less costly and may be more readily available where there may not be access to expert or other microbiological tests. MLR may be useful alone or as part of a diagnostic algorithm, specifically for children with confirmed TB disease. We found that MLR was not a useful diagnostic marker for children in the unconfirmed TB group. We also showed that MLR declined with treatment and that it may be potentially an early biomarker of treatment response. I'd like to thank the following organizations for their support and our colleagues at the University of Washington and University of Nairobi, and Dr. Cranmer for her mentorship. Thank you.
Thank you, Rewa. Very interesting question. I'll just run it. Exactly.
Did you see a difference in the MLR ratios by age of the children? Like if they were a bit older, was the ratio more pronounced than if they were younger, or was it all pretty uniform?
We didn't break it down by age, but you might have noticed that the children in the confirmed TB group were older, and that just kind of fits in with our knowledge of how, as children get older, they may have a higher TB burden and be easier to diagnose microbiologically. But no, we didn't break it down by age.
Additional questions?
That was a very interesting talk. I just wanted to know, does MLR have a range? Is it like very low MLR can also be anyhow significant?
So we did look at MLRs below the 5th percentile and above the 95th percentile, the distribution in our cohort, and we found that it had a lower sensitivity for identifying children with confirmed TB disease, but it did have a specificity of 90% or so. But other studies have limited MLR to less than 5th and greater than 95th percentile and found that it performed well in their cohorts, but that was in adults, I believe.
Great. Maybe a final question as we wrap up. Are there other infectious diseases that change the MLR ratio?
Yeah, there's a paper, I think, by Warimwe and colleagues that showed malaria. Children with malaria could be identified with a higher MLR. And of course, the MLR has also been shown to be useful in cancers like multiple myeloma and sarcoma.
Thank you very much. let's invite Niraj Raizada for a second talk. Over to you, Niraj.
Hi. This is a presentation from the same project where I'm basically presenting a sub-analysis of the infant age group. So some of those slides might be repetitive, so I'll skip them through. Here I'm presenting the sub-analysis of the infant age group, which we have defined as below 2 years of age. And the data is drawn from April 2014 to October 2017. So basically 2.5 years of data. Infants constituted around 20% of the enrolled presumptive TB cases and 15% of the detected cases under the project. Overall, we enrolled something like 8,000 infants and around 8,800 specimens were tested. So one thing which is quite significant is infants rarely get tested for tuberculosis, and largely their treatment is based on clinical signs and symptoms when there is no response. One of the key reasons why this happens is because clinicians hardly get a positive result on any test. Here we got very good results, and as you can see, only 6% of the specimen was sputum, and we were able to capture a large number of specimens. And one of the key things which made this possible, we relaxed the criteria for the volume, specimen volume. We considered all specimen from the infant age group as precious and tested any volume of specimen which was made available. Again, the testing time was quite rapid. Like all test results were made available on the day one, and the treatment time was 1 day for RIF-sensitive cases and 10 days for RIF-resistant TB cases, which is quite understandable because I don't know of many pediatricians who have experience in treating infant MDR. So, again, 3 key results which I would like to highlight over here. Upfront expert testing enabled detection of quite complicated forms of infant TB, and that too in a quick turnaround time. We overall 465 TB cases were detected, of which 5.8%, 5% were MDR. 75% of these cases were pulmonary TB cases, of which 5% were rifampicin resistant. These are infants. Another 20% of EPTB cases were detected, again, within 1 day, of which around 5% were rifampicin resistance. Around 4% of the cases we had both pulmonary and extrapulmonary specimen, which were positive for MTB, and RIF resistance in these were quite high. Very significantly, we detected of this entire cohort of 465 infant TB cases, 11% were TB meningitis cases, of which a high proportion were RIF resistance TB meningitis. So without upfront expert testing, you would have missed out all these cases of MDR, and you would have prescribed a wrong treatment to an infant, which is the case normally in routine practice. The second point which I would like to make is the level of RIF resistance which we observed in infants. Now, infants are at no risk, usually considered at no risk of TB and for that matter, MDR TB. And the results which I have presented over here, we saw that obviously most of the cases were treatment naive. There was no prior history of treatment, and most were smear negative. And these results highlight the need for specialized focus for this kind of highly vulnerable age groups and reinforce the efforts so that evidence-based treatment for tuberculosis is given. And also this has a significant epidemiological implications. Infant levels of TB in infants are rarely published, and you will hardly find any publications where we're talking about TB or MDR TB in infants. So this could be used as a very useful barometer for the level of TB and MDR in various countries where you have high burdens of TB or MDR TB. This is a very key thing which we observed. Now, like I showed you in one of the previous slides, the turnaround time was quite rapid, and within 1 day we had provided all the test results, and the treatment was also started in a very quick turnaround time. In spite of that, we observed high early treatment mortality. Of the cohort of 465 infant TB cases which we detected, 53, that is 11%, died. Some died before the start of treatment, some during the treatment till at the time when we closed the data for analysis. 8 of these were RIF resistance. Overall, 40 of the 53 cases, that is 75% of the deaths, had occurred within 2 weeks of specimen collection. And in spite of the quick turnaround time, 30, that is 56%, had died before the start of treatment. So we spent some time and did some pathway analysis that why this has happened, and what we saw that while the parents were quite proactive in bringing the child to the system, and the labs and the systems were very proactively doing it and doing it with the quick turnaround time, the tests were not being prescribed quite promptly, and there was significant provider delay in prescribing expert testing for infants, which might have caused most of this mortality. So to summarize my presentation, so doing upfront expert testing and doing evidence-based diagnosis for infants for tuberculosis is quite feasible, and MDR levels are quite high. So if you are dealing with with infant tuberculosis, please get this should be followed quite rigorously, and the testing should be prescribed quite promptly so that early infant mortality can be addressed quite efficiently. Thank you.
So we have time for a question or two.
Let's take, there was one just earlier than you at the back. I'll come back.
Hi, those were really nice presentations, and I think anytime we see TB in India gets our